Today we have Dr. Kendra Grubb, who's an assistant professor in the Department of Cardiovascular and Thoracic Surgery at the University of Louisville. Dr. Grubb's clinical and research interests include adult cardiac surgery, transcatheter and percutaneous cardiac interventions, hybrid revascularization, women's heart disease, aortic surgery, and minimally invasive surgery. She got her medical degree at the Keck School of Medicine at the University of Southern California, and she did fellowships in cardiothoracic surgery as well as interventional cardiology. She's authored a number of publications in peer-reviewed journals as well as a number of book chapters, and she's received the AATS 2014 Leadership Academy. She's a member of the 2014 AATS Leadership Academy. With that, I'd like to welcome Dr. Grubb to the conference.
Well, thank you today for showing up today to listen to my presentation. In honor of St. Patrick's Day, we have this nice green hue. I assure you this is not what color I'm seeing, so I apologize for that. And further, I apologize for being late today, but thank you. So in cardiac surgery, we tend to do the same things the same way forever, even if they don't necessarily work. And what happens is very, very disruptive technology that people in this room probably are part of starts to infiltrate what we're doing and makes us question if what we're doing is what we should be doing, and further, is there a better way to do it? And so today we're really going to focus on some disease processes of valves inside the heart and what technology has done, some very, very disruptive technology has done, where we are today, what the future is going to look like, and other ideas for people in this room in terms of what contributions are still to be made. So thank you for that introduction. We're going to talk about percutaneous valve surgery. Here are my disclosures. And this is going to be a summary of what we're going to do. We're going to focus first on aortic stenosis, tightening of the main outflow valve of the heart. We're going to talk about TAVR, transcatheter aortic valve replacement. I'm going to show you some data to support its utilization. And then we're going to talk about the new era, the new devices, what's coming, what the future has. And then we're going to talk a little bit about the mitral valve. So, review of aortic stenosis. In surgery, we start with the problem. I'm sure it's the same in bioengineering. You start with the problem. You look at how many people is this going to help, what's the issue, and how are we going to fix it. So we talk about aortic stenosis, or this picture you see of a very tight outflow valve to the heart. Now those leaflets, those 3 leaflets, should be like butterfly wings. And they should open every time the heart beats. As the heart pumps, the blood comes out, and those butterfly wings should open up. They should open up in a circle. Even though they're kind of triangular, they're going to open up kind of in a circular fashion as they come up into the aorta to let the blood flow out. As we age, or as our valve degenerates, you see these huge chunks of calcium, these rocks of calcium on here, and these leaflets get thick, and as those leaflets get thicker, the mobility decreases. As you can imagine, velocity going through the valve goes up, gradient across the valve goes up. Gradient goes up, the heart muscle has to work harder, and the heart muscle starts to fail. This is a disease of the aging. So, 16.5 million people in the U.S. over the age of 65, 7% of them are going to have aortic stenosis. And 20% of them are going to be female. We will circle back to this idea of why am I telling you 20% are female. We'll come back to that in a little bit when I get into the data. But remember that number, 20% are going to be female. If you look at even the older group, 75 years or older, 2.5 million people in the U.S. over the age of 75, 12.4% of these patients are going to have aortic stenosis. And this population is going to more than double by 2050. So huge numbers of patients that are going to be affected by this and that we can potentially help. The causes, again, we said age-related. So as we age, 65 and older is going to be our target population. Calcium deposits on the actual aging valve. Infection caused by bacteria. So endocarditis can be another reason for this. Rheumatic fever, certainly. Rheumatic fever as a child causes changes to the valve leaflets, and they calcify as we get older. And then people born with a congenital anomaly, like a bicuspid valve. Instead of having 3 leaflets, it has 2. Well, the flow dynamics across a 2-leaflet valve very different than a 3-leaflet valve. And so those valves tend to degenerate faster. And so we see in 40 and 50-year-olds changes of those valves, so that's a younger population that's going to have this same type of disease process. So what's important? When do patients actually start to have symptoms? And so the guidelines for diagnosis were revamped in 2014. And so any valve that's supposed to be somewhere between 2.5 and 3.5 centimeters, when it gets down to an aortic valve area of less than 1 centimeter, the patient is going to, by definition, have aortic stenosis. This is also the time that you're going to see elevated gradients and elevated velocity. Those critical numbers being a jet velocity greater than 4 meters per second, or a gradient greater than 40 millimeters of mercury. You can index this to their body surface area as well as another way to define the actual opening. There are 2 other entities that I won't spend too much time on, but if you can imagine that you've waited long enough that the pump itself isn't strong enough to pump, normal ejection fraction, or how much comes out of the heart every time the heart beats, is 60 to 65%. Turns out if we wait long enough and the heart starts to dilate and can't push anymore, and that ejection fraction is less than 50%, it's possible that the heart muscle itself will not generate a gradient in order to, or generate enough force to create the gradient across the valve, but that the aortic valve area is tight. There was a time where you had to have a combination of these things in order to be a candidate for a transcatheter valve. You had to have a tight valve as well as a velocity that was above 4 meters per second or a gradient greater than 40. What they realized was that we were selecting for a certain population of patients but leaving out a big group that may have a failing ventricle that we could recover. And so what the test that we do is a dobutamine stress echo. We give them medication to see if we can get their ventricle to work better, prove that there is what we call contractile reserve. If we can prove that, then we will proceed with doing the valve. Those rules have changed within the last year, and now you can have one of the 3 of those criteria. Small valve, elevated velocity, elevated gradient. One of those 3 is criteria enough to proceed with treatment. So again, this is what the valve is going to look like, and this is what the patient's going to look like. When they develop symptoms from this disease process, you're going to see shortness of breath as a sign of congestive heart failure, that failing ventricle. You're going to see dizziness when they stand, or syncope. We'll have patients who pass out every time they stand up, or get dizzy when they stand up because their ventricle is not able to generate a gradient across this valve to get enough forward flow to their head, to their brain, excuse me. And then angina, or chest pain, because the coronary arteries are the first vessels that come off of the heart, and if you don't have enough forward flow across the aortic valve, the coronary arteries, or heart muscle itself, is the first thing that's going to be starved for the oxygen and nutrients it needs. So those 3 symptoms, and what's important about those? So heart failure, we're going to say shortness of breath, syncope, or dizziness, and angina, chest pain. It turns out that if you wait 2 years from the time of onset of symptoms for all comers, 50% of these patients are dead. By the time they start symptoms, 2 years later, 50% are dead. The worst prognosis is heart failure, so shortness of breath. And we say about 16 months, 50% are dead. And so this is something where we're talking about an elderly population. They may just be saying, I'm getting older, I'm 85 now, I'm slowing down. I can't do what I used to do, but what they're doing is they're self-limiting so that they don't have shortness of breath. And if you did the echocardiogram, you would find those high velocities or things. So we want to identify these patients and treat them. Another sobering perspective of this disease process. You're better off to have breast cancer, lung cancer, colorectal cancer, prostate cancer, ovarian cancer than you are severe aortic stenosis, because the prognosis at 5 years is dismal. 3% survival at 5 years for this patient population. But we also know if we treat it, that these patients get better and we get them back into a normal survival curve. So what you see here is symptomatic patients who did not have any type of valve replacement or repair, and again, 50% survival between 1 and 2 years. If we intervene and are able to do surgery, then they are going to move up to the red solid line. So we've moved them from here to here. So they were symptomatic and they had an aortic valve replacement. Alternatively, if there are patients that have the numbers but don't have the symptoms, and we treat them, they also do better. there's a huge survival advantage, as you see here. Out at 15 years is where we get to that, not even 50% mortality. So huge problem for these patients. And because they're often elderly, we're talking about a patient population who's 65 or older, only less than 40% of patients are ever discussed with a surgeon about helping these patients. And they're told they're too old, they're too sick, you should go home and die. And so this is the type of patients we're talking about. Traditionally, open heart surgery was the only option we had. It requires a sternotomy, where we open the breastbone. We then have to go on the heart-lung machine, stop the heart, stop the lungs, cut out that old valve, and sew in a new valve. And this is a depiction of a mechanical valve. Well, newer technology came along and said, we can put a new valve in that position, and we can do it without the incision. We could put a wire up through the groin and use the patient's anatomy, go backwards up through the arterial system, put a wire into the heart. We could go through the artery that goes to the arm, or make a tiny incision in the top of the breastbone and go straight into the aorta. Or worst case, we could go straight into the apex of the heart, make a little incision between the ribs. And this is what transcatheter valve surgery is. It's minimally invasive. It's now totally percutaneous, meaning no incision at all, just a puncture. And this is what we're able to offer patients. So we'll talk a little bit about who is approved for this. It is FDA approved for severe symptomatic calcific native valve aortic stenosis. And now also, if someone's already had a valve that's been replaced and it fails, you can put one of these inside. It has to be determined by a heart team that they're a candidate. That consists of a cardiac surgeon and a cardiologist, and actually 2 cardiac surgeons have to see this patient and say that this patient is inoperable or at high risk for open surgery. What does inoperable or high risk mean? It means that they're symptomatic and their risk of mortality from an open surgery is 8% or higher. So risk of dying from an open heart surgery, 8% or higher. There are other features that make people high risk. So frailty, previous sternotomies, previous open heart surgeries, a porcelain aorta where there's so much calcium in the aorta that we wouldn't be able to go on the heart-lung machine or open the aorta because that patient's anatomy wouldn't tolerate it. Advanced liver disease, a hostile chest due to previous radiation. So those are all going to be features that are going to tell us this patient is high risk for surgery and should be a candidate for a transcatheter valve. What does the patient typically look like? They're old, they're frail, they have had multiple surgeries, they may have kidney disease, diabetes, etc. And then we see these guys. They're very old, they're very frail, they have lots of things wrong with them, but they love life. And this is who we're trying to treat right now today. Is this person who's loving life, maybe 100 years old, but clearly doing well, and has this disease process that, you know, she is probably not going to make it another 1 to 2 years. So the data supporting this. If you can imagine going back to the original trial started in 2007. The device was invented first in man 2002. 2002 first in man. 2007 we started trial. That original device was the size of my finger. It was not flexible. It was clunky. It was hard to use. We'd never seen anything like it. We'd never seen anything like it before. And we decided that we were going to take groups of patients who were on average 84 years old, and 94% of them were in class 3 to 4 heart failure, meaning they get short of breath walking on flat ground, they can't walk upstairs, normal activities make them short of breath. Their risk of dying from open heart surgery was 11.8%, and we were going to take them to the operating room, either operate on them or give them the transcatheter valve. And at 5 years, what we found was that there was no difference between, in this trial, this was the original valve, no difference between the transcatheter valve and the surgical valve. So at least we proved non-inferiority. And that was the goal of the partner trial. So for all of the metrics, non-inferior. The question often becomes durability, right? So if you're going to have a new technology, it has to at least last as long as what the gold standard is. So what they also showed is, in terms of durability, the mean gradient across the valve, as well as the orifice area, stays very, very much the same over 5 years, suggesting that at least up to 5 years, durability is good. Another valve was available slightly later, coming into the US. This is called a core valve. Now, going back to this other valve, this valve here, the newer generation is made of bovine pericardium. The leaflets are the sac around a cow's heart. The metal portion is cobalt chromium. So you're able to shrink it down put a balloon inside and blow up the balloon to get it to be the size you want it to be. The newer valve, this is made of nitinol, so it's a memory metal. The leaflets are porcine pericardium. So I can take this valve, scrunch it down to the size of a ballpoint pen now, and as I release it, it's just going to go back to the size that the nitinol wants to be. And in this trial, the patients were not quite as sick. Their risk of dying from the operation was 7.3%. They were still octogenarians, average age 83 years old. Lots of things wrong with them. And what they found with this valve in 795 patients was that actually the transcatheter valve, here demonstrated in orange, survival was even better, right? So it's statistically better than the surgical arm of that trial. Looking at stroke, so anytime we're talking about calcium in the aorta, we always worry about stroke. Turns out the stroke risk at that time was about 10% from the transcatheter valve and 16% at 2 years for the surgical valve. So we're seeing that stroke risk is less, mortality is better, durability, remember following the orange here for core valve, durability is better. The orifice area is larger, the mean gradient is lower. So this is a superannular valve. The sapien valve, that first one that I showed, sits exactly where the old valve used to be. This one sits up higher, so it sits in the annulus to anchor, but the valve itself is up above. So you're able to get a larger valve for the per size. So we get back to TAVR in women, right? So why did I bring that up? It turns out that female gender is a known risk factor for mortality in numerous surgical studies. Everything that I do on the open surgery side, women do worse. Coronary bypass grafting, all of the valves. We talk about even medical management. Women do worse. Interventional cardiology, stents, things like that, women do worse. We don't necessarily know why. We're trying to figure that out. Part of it is at the time that they enter the system, they're usually sicker because they don't present with the normal symptoms, and so they get sent to a bunch of different doctors first. But they do worse. It turns out when we talk about aortic stenosis and transcatheter valves, they actually do better. So for the TAVR arm, transcatheter valve arm, in that partner trial, the mortality was lower for women. And for surgery, here you can see it's not much different. When we look at just the females, here you see that difference between the surgical arm and the transcatheter arm. They do better at 2 years. And this data has then increased to 3 or 4 years now, and this curve continues. If we look at the transfemoral arm, this is where you saw the greatest difference. So if we were able to go up through the groin and use that as our access route, the patients did the best. If we went through the ribs straight into the base of the heart, it wasn't any different. There was no survival advantage compared to surgery. And this is just another way of comparing the transfemoral versus the transapical head-to-head. And what you can see is really the survival advantage comes from doing this via the groin vessels. However, this is still that first generation device. This is a big, clunky instrument. And the major bleeding, when you compare for females, higher in the surgical arm, strokes much higher in the transcatheter arm, and major vascular complications higher in the transcatheter arm. So certainly areas for improvement, right? We would want to drive those numbers down. We want to decrease our stroke. So we think about what can we do to decrease stroke? Well, we can get better. We can make a smaller device. We can make a protection device maybe. What about bleeding? Well, smaller device, less complications. So we start thinking about what we can do to make this a safer procedure. And this new era starts to begin. We see explosive growth in this as the device gets smaller, as we are able to identify appropriate patients. This is now implanted in over 65 countries, and there are over 200,000 implants to date. Explosive growth in this technology, and you see that middle bar in the US, how that is expanding every year. And then within the next 10 years, it is expected that TAVR will increase 4 times. In Germany, where they were early adopters of this, they have already eclipsed the number of aortic valves that are done open. More patients receive transcatheter valves than open valves in Germany today, which we may see here, we may not. It'll depend on our government. Again, to remember, again, there's this large population of patients who are untreated. Right now, this transcatheter part is just high risk and inoperable. This is going to be people who are lower risk. But there's a huge group of patients who are still going untreated. And so that's the potential for this type of technology. Getting back to those guidelines, we talked about kind of the guidelines to get you the diagnosis, but what about what you do with those patients today? So if they come in with the, I have severe aortic stenosis, and you're low risk, today you go to surgery. If you are prohibitive risk, then maybe you get a TAVR, maybe you get sent to hospice. And if you're high risk, you're probably going to get a TAVR today, you could get surgery, but that's the way the guidelines look. Interesting, there are now 2 trials that have gone on for intermediate risk. So move that risk down to 3 to 8% risk of dying from open surgery. Compare those to surgery. That's the SUR-TAVI or SAPIEN 3 continued access now. So that trial is done. And we're going to find out next month what their 1-year data looks like for the SAPIEN valve. Low risk is just starting. So now we're going to be able to take a 65-year-old down to minimal risk in a trial compared to surgery and see what the answer really is in terms of who we can use this device on. These new devices went through huge changes. So I'm going to talk a little bit about the first device that came onto the market. Again, we said in 2002, the very, very first in man happened. And this went through a sheath that's 24 French. That is huge. French size divided by 3, that's millimeters. In 2006, 2007, the trial starts. Now the device has some iterative changes that you see here. It's gotten shorter, it's gotten a little more streamlined, it's going through a smaller sheath. Fast forward to 2013, SAPIEN 3. This was like you used to drive an old beat-up Volkswagen, and now you just bought a Maserati, and the difference is huge. They've added a sealing skirt in order to prevent leaks around the valve, because as you can imagine, putting a circle in something that's irregular and calcified, we would have leaks between those. They've added some geometry to the stent cells so you can make it even smaller. Those stent cells on the top, of course, as you push those together, it's going to be longer but thinner. And so what we can do now is put that through a 14 French sheath. So any patient who has 5.5 millimeter arteries, we can do this for. And then the newer device that isn't even in the US yet, this is still in, this is called a Commander or something like that. We will be seeing this. And that is the next change that we'll be seeing. So just to talk a little bit about how this is done now, I'm hopeful that this video will play. But this is the deployment of a balloon expandable SAPIEN 3. That device that I just said is the Maserati of transcatheter valves. So we're able to make a puncture in the artery in the groin, in the femoral artery, and place a wire up into the heart. This is the catheter that then is going to have the scaffolding in it in order to hold the valve. You can see that the valve is in line and is not yet loaded onto the balloon. This valve then will be loaded onto the balloon in the aorta. So the descending aorta is taking blood down to the legs and the rest of the body. The device is loaded onto the balloon. It's then threaded around the aortic arch, where all the head vessels come off, right? So this is what someplace where we know we had strokes because we sheared off calcium as we came around. This device you can steer around. It's not just a stick. It then goes into the aorta. It has a turning wheel, so we can put it right in the center of the valve. This is done under a period of rapid pacing, so we'll make the heart rate 180 beats per minute, because that fast the heart doesn't have time to fill, so it can't eject, push the valve out. So you're going to see here in a second. This valve also has this turning wheel that we can move it millimeter to millimeter, just get it exactly where we want it to go. We're doing this under fluoroscopy, which is an X-ray. And then rapid pacing, the heart's fibrillating, essentially. The balloon goes up and the valve is in, holds on by radial force and friction.
Wow.
So with that new device, what you see, risk of dying from that at 30 days, 1.6%. Risk of stroke, 0.8%. We stopped shearing off calcium. We were more careful when the valve is across the annulus, careful inside the valve, and the stroke rate goes down dramatically. For the intermediate risk, similar data. Extremely low mortality, extremely low stroke rate. For the European data at 1 year, because we are waiting until next month to have our own 1 year data, what you see at 1 year is that the mortality is now 91.6. When we were talking that partner 5-year data that I showed earlier, we were down to like 26%, right? We're at 91% survival here, freedom from all-cause mortality. And as you can see here, the first generation to the second to the third, we've gotten so much better with this. And these are high-risk patients, inoperable patients. Now, there are still some problems. Vascular complications. When I talked to you about the data with the women, it was about a 10% vascular complication. Now we're down to 2. The new problem is we added that sealing skirt. It pushes on the conduction system. The conduction system is the electricity through the heart. If you hit it hard enough, you will have no heartbeat at all. And so the pacemaker rate in the US is about 13% with that device. In this trial, it was 4. But still, permanent pacemaker becomes another issue. Because if we're going to put this device in a young person, you want a valve. You didn't want a valve in a pacemaker. And that pacemaker you have for the rest of your life. So these are these types of problems that we're going to be addressing as we go forward. We fixed the paravalvular leak problem, right? We put a sealing skirt. But that skirt then caused us to be larger right where the conduction system is. So now we're trading leak for pacemaker. So more ideas for the future. That other device, the Medtronic device, this is their newest generation. This is called an Evolute. This goes through a 14 French sheath. Now vessel size is down to 5 millimeters. This is the smallest device on the market in the US. This is repositionable and retrievable. Unlike that other one, when the balloon goes up, it is where it is. You can't go back and get it. This device, because it's made of nitinol, we can go back and get it, move it to where we want it, put it in the exact perfect positioning. And so you see that they've streamlined it. They made it shorter. They made the skirt go all the way down to the bottom of the stent cells. This would have leak around it. They've solved that by bringing the tissue all the way to the bottom. The valve, again, is supraannular. So the valve itself is up here, but this is the portion that's going to sit in the annulus. You worry less about it being circular because the valve sits up on top. Where the valve actually is circular. And here again is this idea where if you put the valve too low into the heart, that you could go and retrieve it and move it back to where you want it to go. And with this device, excellent result. Zero mortality at 30 days, 6.7 at 1 year. And this became the standard for the lowest mortality of any device on the market, 93.3% survival at 1 year. There are newer devices. This is direct flow. So when we talk about the problem was solved with the first device, but when we figured out we could put a valve inside of a valve, we came up with all these other problems. What about paravalvular leak? What about stroke? What about the pacemaker? This is a company that came out and said, what if we did away with a lot of the metal? We didn't have a balloon to deploy it. We made it flexible. We made it repositionable. So this is a direct flow valve that's going to be, that is in trial right now. And imagine this is just a nice soft valve that goes into the heart. We fill those rings with saline that has some contrast in it so that we can see it. We're able to fit that into the annulus, fill up those rings, make sure that we have a good seal. And if we like it, then we exchange that saline for an epoxy. And then the valve's there forever. Very interesting way to address this. Another way to come up with a way to address that large population. Now, these are kind of the 5 mainstream devices. You see 2 that we've already talked about, and then this direct flow valve. We have the Lotus and a Jenna valve. There are a whole host of other companies coming out with, we've got one better. We're going to fix those little problems. So a little bit about TAVR in Louisville. My team, 209 valves. Our mortality rate is about 3.11%, and our stroke rate is 2.1. We started doing these awake. We said, we can't fix the problem of paravalvular leak. We'll wait for you guys to figure out how we're going to fix that. But how can we make the patient experience better? We're going to do this awake. These patients are 80 and 90 years old. So we looked at our first 30. They're awake. This patient has no endotracheal tube. He's talking to us. He just has a face mask. He doesn't have a lot of invasive catheters. And what we found after doing 115 is that they do really well. If we look at our first 30 of these patients, these are the same sick patients. We had 0 mortality in hospital. We had 30 days, 1. But they're staying in the hospital a median of 27 hours with a post-op total length of stay of 1 day. When we looked at our first 50 compared to the previous who were under general anesthesia, they were asleep. What we found was that there aren't a lot of differences between the two groups, but what we did find is that they were discharged to home instead of having to go to a nursing home. And their post-op length of stay went from 4 days to 1 day. So from my team's standpoint, these are the types of changes we talk about. These are the things that we want to do to try to make the patient experience better, to make it safer. And then we rely on the engineers to make the device that much better for us. So what we concluded about our minimalist approach was that it was safe and feasible, that it was lower length of stay and ICU stay, they were discharged to home, and that there were some cost savings. And as we expand our protocols, these outcomes even get better. We've done 115 now, and we'll be looking at that data and see where we are in terms of the comparison to previously. So now able to put a core valve inside of a failed bioprosthetic valve, and for both valves available. We have the intermediate risk trial, we have the SURTAVI trial, which is also intermediate risk, and now low risk trials. So we started with this high risk and inoperable group. We moved down to trials for intermediate, and now trials for anyone 65 and older. So it's very disruptive technology, very much changing the way that we think. And along the way came, how can we treat patients better? How can we work as a heart team? It used to be that cardiologists and cardiac surgeons, they never played in the same sandbox together. They had theirs and they had theirs, and they talked to each other only through a patient. Now, what this technology has done is it's brought the cardiologists and the surgeons together and said, you guys need to figure out what's the right thing to do for this patient. And it's a totally different era. We're going to quickly talk about mitral because this is truly the new frontier. So we got through the transcatheter valve, we talked about the aortic valve. Well, what about the mitral valve? Well, here this picture depicts something that's really interesting. This is the aortic valve, right? So it's the main outflow valve. This is the left ventricle. It's the main pumping chamber of the heart. Mitral regurgitation happens when the blood comes back from the lungs. It's supposed to go into the atrium, through the mitral valve, and out the aorta. But if the leaflets of the mitral valve don't work, then it goes backwards into the lungs, into the atrium, and the patient has shortness of breath. And so here, just want to focus not on all of the words, but degenerative is the leaflets have a problem because one prolapses, or one has, a prolapse should be like this, flail, so the cords that are supposed to be like parachute cords are broken. Functional is where the ventricle itself doesn't work, so it pulls the annulus apart. So things like having a heart attack would make the ventricle not work and pull the leaflets apart so they can't touch in the middle. Right now, functional mitral regurgitation can be treated with devices that we have. These are still in trial. So the problem here, because we talked about earlier, we need to find out a problem and see if we can fix it. Nearly 1 in 10 people age 75 or older have moderate to severe mitral regurgitation. And approximately 4 million people have significant mitral insufficiency with an annual incidence of 250,000. But only 50,000 of these patients are going to have surgery. Huge population of patients. They were just being told, you need to go home to die. That's because it's happening to an older patient population. Now, when we went back to that picture, 40% are going to be this type, degenerative. 60% are going to be this type, functional. Mortality, over 50% at 1 year with severe. So huge problem, right? So we know that there's a huge unmet need. There's a large population of patients that has this problem. And this was the initial solution. What if we could go in and we could just clip those leaflets together? And this is what the device, this is a mitral clip. It's FDA approved for degenerative, so just this kind of mitral regurgitation. The device looks like this. It's like playing a video game. You're using echocardiography and fluoroscopy to try to position this clip inside the heart in order to be able to, oops, I've got too many things open here. In order to, so here's the problem. The device here, they were talking about MR, so the regurgitation, instead of going out the aorta, going into the, it's going backwards into the atrium. Here we're going to make a puncture in the groin, go up through the venous side, so the blood returning to the heart. We're actually going to poke from the right side to the left side of the heart, go from the return side to the pumping chamber. This is all just looking at fluoroscopy and transesophageal echo. We're then going to place a clip inside of the heart, carefully steer that clip without putting it into the wall of the heart, position it above the leaflets, find the middle point, find where the leak is, then drop the clip below, and try to grab those leaflets inside the heart while the heart's beating, and we're watching a video game. There's got to be a better way, guys. Help me out here. Right? Like this is an idea that works, but I wouldn't say that it's the best idea. I would predict that even though we do these right now, that I would imagine this device in 10 years we laugh that we did this. But this is the only thing we have right now. This is a mitral clip. So we go in, we come up, we grab the leaflets, these little grippers come down, you close the clip. The clip is actually about the size of a dime. If you don't like it, you can open it again. You can move it along the valve leaflets. Close the clip. Mitral regurgitation goes away, or doesn't ever really go away. It goes from severe, where the patient has symptoms, down to hopefully mild, where there are fewer symptoms. Then we release the clip and get a final assessment. So that is the state of affairs for MitraClip today. So it's a beating heart procedure, no bypass, real reduction of mitral regurgitation. You can reposition the clip, usually stay in the hospital 2 to 3 days. It's an edge-to-edge repair. This is what the tissue looks like after it heals. So you've taken a fish mouth mitral valve and made it 2 smaller orifices with a dog bone shape. And what we found is it works, kind of. It takes the regurgitation down. So if we went from severe at baseline, this gray, we find at 1 year we're making patients feel much, much better. We have patients usually in the 3 to 4 range, and what you're seeing as that 3 to 4 range is significantly reduced by 1 year, but it's not really a lasting procedure. So it's a band-aid for people who have nothing else, who are going to have 50% mortality at 1 year. We are making them feel better and having them live longer, but we understand it's not going to last forever. We've done 27 of these. We've had no deaths, no strokes, and the patient should usually go home the next day. But what's the real future? Because I mentioned this doesn't really work. It kind of works. It makes them feel better. It keeps them out of the hospital, but it's not really a solution. The solution is going to be a transcatheter replacement, just like that transcatheter aortic valve. We took that same thinking and said, what can we do is replacement. And that's what we're seeing. And there are something like 38 companies right now trying to come up with a way to put a valve on a stick and get it in the mitral position. Much, much more challenging. The ventricle moves much more than the aorta does. The aorta has a fixed structure around it. You can put something in there and have it hold on to the calcium. Here, the heart, every time it beats, that posterior portion of the heart is coming up. So if you put something metal in there, eventually it'll erode right through the back of the heart. And unfortunately, that's what we're learning. So this valve came on to trials, first-in-man trials, taken off because of such high mortality. They've made some modifications, it's back on. This is yet one more way to try to figure this out. You can see these hooks. They think that you're going to be able to go in and grab those leaflets and deploy this valve and it's going to hold on. I don't know. Is it going to work? That one they found immobilized. So it would stay on when you let it go. 30 days, they were falling off. That wasn't the right answer. Here's another version. And again, there are multiple thoughts about how are we going to do this. But this is the new frontier, the mitral valve. And what are we going to do in order to fix this problem of mitral regurgitation? Remember, there's 2 different types. There's functional and degenerative. Degenerative, the heart's normal, the leaflets don't work. Well, maybe there's one solution for that, and a different solution for the leaflets are normal, they just don't touch because the heart's bad. I don't know. So, really, we look to people like you to come up with this idea, because certainly as surgeons, we'll just go and cut it out, and if you're too sick to cut it out, well, that's what hospice is for. That's not a good solution. There's a huge unmet need, and this is where we need to come up with something. So, thank you.